Good afternoon, everyone. This is DeeAnne McCallin with CalHIPSO. Thanks for joining us today. We are continuing our webinar series with a monthly presentation. Today is on the public health objective for Stage 3 meaningful use. Thank you for joining us today. We do see a number of you in attendance, and it is just the top of the hour, so I'm sure folks are still dialing in. Please use the chat box. It should present to you as chat. It could present as questions. If you have any technical difficulties or challenges, this will be posted and published on our website as a recorded webinar that you'll be able to access in the event. I hope you don't have them, but in the event you have any technical difficulties or if you can't hear any of us. But again, thank you for joining. Happy New Year. We're starting a new calendar year and program year for meaningful use, which is officially called Promoting Interoperability by CMS, though they do allow states to continue using the term meaningful use for the continuity of the program and familiarity for the folks that don't read the Federal Register and the rulemakings throughout the years. A little bit about CalHIPSO. We were funded in 2010 by our founding partners, the California Primary Care Association, California Medical Association, and the California Association of Public Hospitals. We were a regional extension center, the largest one in the country, helping everyone to adopt and begin using electronic health records. Since the end of the ONC program, we have been working with DHCS for the California Technical Assistance Program, helping eligible professionals to get into the program before it ended to new participants in 2016 and to meet Stage 2 and Stage 3. We do work with the Quality Payment Program for the small, underserved, and rural support technical assistance in collaboration with the contractor for California Health Services Advisory Group. And we've been doing some other smaller projects with it, which have been showing a lot of potential in where quality improvement can be had under diabetes management, and another one on encounter data submission. So you probably all know a lot about CalHIPSO, but if you didn't, that's some of our background, and a lot of information is available on our website as well. Joining me today is Steve Nickel from the California Department of Public Health, as well as Melanie Epstein-Corbin. And I'm going to give a little bit of bio, not too long, but again, it's while people are dialing in and joining us today. Steve is the chief of the Registry and Assessment section of the California Immunization Branch. His section oversees the California Immunization Registry. He received his BA in microbiology from the University of California, Berkeley, and his PhD in infectious disease epidemiology from Johns Hopkins. By training, Anyway, Dr. Nickel ran his own NIH-funded academic research program at Johns Hopkins and the University of New Mexico for 13 years before becoming the head of the immunization program for the state of New Mexico in 2002. He has been with the California Immunization Branch since 2006 and section chief of the Registry and Assessment section since 2009. Melanie Epstein-Corbin, MPH, has earned her Master's of Public Health and Epidemiology and has a background in public health research and program development. She spent a majority of her professional career at UC San Diego conducting clinical trials, program evaluation, and data analysis for the Department of Family Medicine and Public Health and UCSD's Environment, Health, and Safety Department. Melanie joined the California Department of Public Health as the Electronic Case Reporting Coordinator in 2017. I thank them both very much for joining us today. I'll be navigating through most of the slide deck and the presentation, and then Steve and Melanie will join in for their sections and give the presentation during that. So with no further ado, we will move on. Whoa, not too fast though. The CMS objective and the measures that are within the one objective of the public health for Stage 3. I do want to begin with a disclaimer that the information that I'm using provided by CMS on their public resources page of the EHR incentive program. They do still only have 2018 Stage 3 Meaningful Use published. Most of the rules for 2019 Stage 3 Meaningful Use are the same, but there may be some subtle small differences. So just be aware that any of the resources within this slide deck that we will have posted and shareable are from 2018 Stage 3. And I have been told that CMS is expecting to have updated Medicaid Stage 3 specification sheets and information resources soon. So hopefully that comes this month, maybe February at the latest. Hopefully you're familiar with the spec sheets that CMS has. They're super useful. This is just a portion of about a 6 to 8 page specification sheet on this one objective. Stage 3 has 8 objectives, and today's webinar is focused on only this one objective, objective number 8, where the full title of it is Public Health and Clinical Data Registry Reporting. This is where there are 5 measures within the objective. A lot of this information is going to be resources for you to refer back to. At the end of the webinar, if there's time, I can go back to slides. So if you want to jot down a slide number, if you have a question on it, or if I went past it too quickly, or if you have any questions or resources, we can go back to these, assuming there's time at the end of the webinar, where we do expect to field some questions and hopefully have some answers for you. So within this objective, what is different for Stage 3 is now we have 5 to choose from, and as part of your successful meaningful use attestation, you need to be able to attest yes to 2 of the 5. So up through modified stage meaningful use Stage 2, you had to attest yes to 2 out of 3, and that 2 remains the same, but now your options have grown to out of 5. It's a yes-no attestation, but absolutely know the details of what you are attesting yes to. It is auditable, and DHCS will be auditing meaningful use over the upcoming years, and you want to make sure that if you attested yes to an objective, any objective, that you have the details in the documentation as to what supported that yes. It's very simple to work through the California state level registry and attest yes and be able to pass meaningful use. But will you later down the road be able to pass a meaningful use audit for having selected that yes? The 5 measures within this objective are the immunization registry reporting, syndromic surveillance, electronic case reporting, that is new for Stage 3, public health registry reporting, and CDR, which is the clinical data registry reporting. Not going to read this slide, much probably to everyone's pleasure, but within the objective, CMS has laid out that a meaningful user needs to be in active engagement, and there's 3 options of active engagement, 1, 2, and 3. Completed your registration. So there's a timeline within 60 days after the start of your PI or meaningful use reporting period, you need to have registered. So somebody back in December was asking, oh, can we register now, approximately December 10th? And my answer for 2018 MU was no, because that was later than the 60th day of their 90-day EHR reporting period. So be in active engagement, at the very least, option 1. Option 2 is that you are testing and validating and that you are working with the registry. If they've reached out to you, are you responsive within 30 days? So you don't want to get kicked out of having been in an active engagement, option 1 or 2. You want to be responsive. Or are you in production? That's the ultimate goal. We would love to see everybody in production and getting a benefit for your practice. So for being a participant of the registry, which is more meaningful than simply attesting yes to meaningful use. We want you in production and that it's adding value to your clinical workflow. One of the great resources out there is the California Department of Public Health HIE Gateway. And the only thing I don't like about this gateway is probably the title for the HIE, because it misleads us all towards HIE and the HIE objective, but it's all about the public health meaningful use objective from the way I have used this resource over the years. But it is an excellent fairly deep web page, publicly available for everybody. It's a resource for stage 3 meaningful use. It's been there for the last few years. And it's also your entryway in how to register. So before beginning the gateway, this is a screenshot of what the home page or one of the pages in there, and it gives you a lot of resources. The next couple slides have some of what this CDPH.ca, the HIE CDPH.ca.gov offers. There's program-specific information, so you can just scroll down when you first bring up the URL, and you can choose which one you're actually going in to look for. In a moment, I'm going to be passing the baton to Steve for the verbal about the California Immunization Registry. So this is where the next part of the webinar is going to follow through the 5 measures that all feed towards the one objective. And again, you need only do at least 2. You could attest yes to all 5 if they work for you and they benefit your practice. They're all resources out there. To meet stage 3 meaningful use, you need at least 2, but you can certainly attest yes to more than 2. This is the information from the HIE Gateway website. And I'm going to let Steve take it from here to give some more detailed information on the CARE system.
Thanks, DeeAnne. So I think most of you probably are aware that the CARE system is still a CARE system. That is, it's 3 separate registries. It used to be 10 separate registries, but we've consolidated it down to 3 at this point. And we're hoping in 2019 to actually be able to move data from the 2 independent registries, CARE San Joaquin and CARE San Diego, into the larger CDPH registries, CARE 2. So I'm mostly going to be talking about the CARE 2 process today. If you're in the other counties, the San Joaquin counties or San Diego, you probably have a separate stage 3 process. So refer to your jurisdictions for any sort of requirements for stage 3 in those areas. Next slide. So just to give you a sense of the scope of what's happening at CARE 2, most of the submission these days is through data exchange, partly a function of the fact that people are wanting to receive incentive payments for meaningful use. So we've had a major increase over the last meaningful use years in providers coming to us to submit immunization data. This is, we have about 5,500 submitters. 900 or so of those are still submitting manually, but the vast majority of submitters are submitting through data exchange. So that's beneficial to us, and it's beneficial to the site submitting data because they only have to enter data once. They enter into their EHR, and messages, HL7 messages, are sent to us containing patient information and vaccines. So that's beneficial for both sides. Next slide. So this was referred to at the HIE, from the HIE standpoint, from the gateway standpoint, but I just wanted to sort of further explain our definitions for who's submitting. We have direct submitters who basically have an EHR that submit directly to CARE 2. We also have the majority of sites are actually using a sending facility to send information to us. So they send information to a sending facility who then forwards the information to us. And then obviously we have the sending facilities as a third category. So we define those in the CARE world as entities that submit for 2 or more sites. That is more than one site. So these can either be HIEs, EHR hubs, medical group hubs, or in the case of the Kaisers, large health plans that send from their central data warehouse. So those are the 3 entities that register at CARE. Next slide. So this is just to give you a little bit of those 4,600 sites. 4,300 of these are actually sending through a sending facility, either an HIE, an EHR hub, a medical group, or the two Kaisers that we consider to be health plans. So this is just for your information to give you a sense that HIE submission constitutes about 20% of data coming in. EHR hubs are the majority of data, or I wouldn't say the majority, but they're the largest group of data coming in, almost 1,800 sites sending through EHR hubs. Medical groups are the next largest entity. So we have a mix of data sources coming in, but the vast majority of sites are sending through an intermediary sending facility type of one type or another. So this is the majority of data coming in through data exchange. Next slide. So for stage 3, our process is fairly simple. We actually have a first step, which involves sites doing a SurveyMonkey survey, which registers their interest. It also has questions about their readiness. Have you talked to your EHR vendor? Is your EHR version ready to essentially enter into bidirectional messaging, which involves sending queries, patient queries to care, and after we receive a query and match the patient, we return essentially patient history and/or patient history plus recommendations. So the first step is the readiness survey. Then once our staff has determined that a site or a EHR hub or an HIE is ready to enter into the testing process, we submit to them a test plan that involves 8 patients that are entered into their EHR system. They send queries to our test site, and at the end of this process, they basically take a post-testing survey, which verifies that they've actually completed the process. They've returned patient information. We review that post-testing survey, and if everything looks kosher, they're basically onboarded to bidirectional. Now, I just want to reiterate that this is the CARE 2 process. Your mileage may vary for CARE San Joaquin and CARE San Diego. So if one of those counties covered by those 2 independent registries, you'll have a different process than I've described. So next slide is just to summarize where we are currently. A QBP is the message type that's sent as part of this bidirectional query. As you can see, we're in the millions of messages received each month, so we have a lot of sites that are currently in a bidirectional production submission. We're closing in on 500 sites, but obviously meaningful use in 2019 will drive that further up. We're hoping to get that up into the several thousand sites. But it's a fairly simple process getting onboarded for bidirectional. We haven't actually done much in the way of acknowledging achievement of bidirectional status for the purposes of meaningful use. We'll probably do that towards the end of the year. But I encourage any sites out there that are interested to take those steps and begin the process. So that's really all I have to say. Obviously, at the end of the presentation, we'll open it for questions, but I'll turn it over to you, DeeAnne.
Great. Thank you, Steve. Let's see if I can advance the slide. All righty. Measure 2, syndromic surveillance. So CDPH, the California Department of Public Health, does not have a syndromic surveillance system. It is predicated upon the local health departments, and anybody who's interested in attesting yes to this measure out of the 5 for 2019 stage 3 meaningful use should check with their local health department. Within the HIE gateway, there's an excellent matrix that you can access, and it has every one of the different registries that had those gray boxes on an earlier slide, but I just brought in the syndromic one right here. You put in your county, it says whether it's acceptable or not, yes or no, has a contact number, and oftentimes it'll have a note, like this one for Sacramento County says hospital emergency departments only. So if you're a small provider and you wanted to look at this to see if you needed to attest yes to this, or if you wanted to attest yes in Sacramento County, this would be, in a sense, your meaningful use documentation as to why you are not attesting to syndromic, and that you would need to look for one of the other of the measures to attest yes to. And then the next couple slides are leading into my introduction of Melanie taking over the presentation and giving. So this screenshot is the electronic case reporting from the HIE Gateway. Again, great resources, great information at this one-stop shop for where you can go. FAQs, contact people. This is some of the information that is on there. As of July 1st, CalReady declared readiness for the use of electronic case reporting beginning January 1st, 2018. So that's a year ago. They were able to use this registry to submit. So that's kind of looking backwards where we're all about the 2019 stage 3. And you do need to see whether your local health jurisdiction prefers you to register through the gateway or through a solution that's through that same capacity matrix, which is excellent. Again, this information is all available on the HIE CDPH website. Just going to do a quick glance to see if there's anything digital bridge. There's information coming from Melanie on that. Again, this is from the gateway, information that's available. And I'm going to pass it off to Melanie. Just let me know when you need to advance slides.
Okay, great. Thanks, DeeAnne. So since electronic case reporting is still so new, with my slides today, I wanted to give a brief overview of what electronic case reporting is and who's leading the development of the national ECR approach. And then I'll dive into some of the MU information and timeline. Next slide. There we go. So electronic case reporting is the automated generation and transmission of case reports from the electronic health record to public health agencies for review and action. ECR will fulfill the physician communicable disease reporting requirements under state law and may also meet the MU or PIP requirements under Objective 8, Measure 3, as DeeAnne stated. And that little blurb up there is just saying that although ECR will improve the method of public health reporting, it does not replace the responsibility of providers to report reportable conditions, especially those marked as immediately reportable, which will still require a phone call. And that provider responsibility language is on our web pages there. Next slide, please. Okay, so who's leading ECR development? So California is one of 7 sites that has been selected to participate in a national ECR pilot, which is being led by the Digital Bridge Initiative. So the Digital Bridge is a forum for key decision makers in healthcare, public health, and health IT that have come together to collaborate on ideas and solutions for a nationally consistent and sustainable approach to using electronic health data. So it's as you can see up there, it's a public-private partnership with the goal to advance information exchange between healthcare and public health. And you'll notice amongst all those logos up there that there are 5 major EHR vendors that have representation on the Digital Bridge, and those are Epic, Cerner, Allscripts, eClinicalWorks, and Meditech. So we're expecting that these vendors will be the first to offer an ECR product or solution to their clients because they are part of the Digital Bridge, but there's nothing out there stopping any other vendor from working on an ECR solution right now. There's also some major providers participating in this initiative, and one in particular that's big for California is Kaiser. We haven't heard when Kaiser might go live with electronic case reporting, but it bodes well for the future of ECR at Kaiser that they're part of the Digital Bridge governance body. And so through this partnership, which is motivated by mutually beneficial outcomes amongst these organizations, the Digital Bridge has designed a multi-jurisdictional approach to electronic case reporting. And instead of reinventing the wheel, they really wanted to focus on using already existing interoperability standards. And one of the other goals was to create a standardized set of data elements that would allow the EHR vendors to really streamline and simplify the development of an EHR vendor agnostic product, as they call it, or a solution for electronic case reporting. So instead of the EHR vendors having to create, one-off solutions based on any particular jurisdiction or region, the Digital Bridge has brought all of these partners together to create a streamlined EHR vendor agnostic solution. Next slide. Okay, so the Digital Bridge is coordinating ECR pilot implementations at sites across different states and cities. So in addition to California, the other pilot sites are in Houston, Kansas, Massachusetts, Michigan, New York City, and Utah. And Houston was actually the first to go live with exchanging data via electronic case reporting as of November 14th, 2018. As it stands right now, California is slated to be third in the nation to go live with ECR using this Digital Bridge approach. And each of these pilot sites consists of a partnership between a public health department, a healthcare delivery system, and a health IT vendor. So the California Department of Public Health has partnered with Epic as our EHR vendor and UC Davis Medical Center as our provider. And initially in this pilot phase, we'll be testing and supporting 5 ECR pilot conditions, which are pertussis, gonorrhea, chlamydia, salmonellosis, and Zika. But of course, after the pilot is completed, all state reportable conditions will be supported. Next slide. Okay, so some of the prerequisites for electing ECR for your MUPIP fulfillment are that the provider must have certified EHR technology. Of course, ECR cannot be done without it. And the provider's EHR system must have the ability to transmit an electronic initial case report in accordance with the HL7 implementation guide that you see hyperlinked up there. So right now, we are encouraging providers to really start this discussion within their facility and to reach out to either their EHR vendor or their in-house IT analyst to really determine if the EHR system they're using will be able to transmit an EICR in conformance with this implementation guide. And you can access that implementation guide on the HL7 website. You need a login to log in, but it's free. So I'd encourage anybody who's interested to log into HL7 and review the implementation guide. So over on the degrees of active engagement, as DeeAnne pointed out, we have opened our CDPH HIE Gateway registration for electronic case reporting. So that would be step 1, is to register your intent to submit electronic initial case reports. We do have a good number who have already registered. As I said, we're still in the pilot phases right now, so we have not moved on to step 2 yet, but step 2 would be active engagement for testing. We are going to conduct user acceptance testing, much like we did for electronic lab reporting. And then once all of the, everything is confirmed that the provider can send and CalReady can receive the electronic initial case report, there'll be a period where, we'll keep dual reporting just for a while to make sure that we're receiving all of the electronic initial case reports that are expected. And then once testing is successful and completed, we'd be moving on to step 3 there to submit live real data. And those 2 notes there at the bottom, once CalReady has given the okay to move on to the next step, the provider has 2 weeks to respond. And I was told that the provider can fail to reply once, but an additional failure to reply may result in failing the measure. Next slide. Okay, so here is a draft timeline for electronic case reporting. As of July 1, 2017, CalReady declared readiness to meet Stage 3 Meaningful Use, PIP, for electronic case reporting. As we said, the ECR registration via CDPH HIE Gateway is open as of January 1st, 2018. So CalReady is scheduled to conduct pilot testing using the UC Davis test data starting this month. And after pilot testing is completed, we'll continue to work with the Digital Bridge to evaluate the pilot outcomes. But during that time, during this evaluation period, we intend to receive real data into our CalReady staging environment from electronic initial case reports from UC Davis Medical. But that'll just be for those 5 pilot conditions during that interim period. One big thing, please note that California's timelines are really affected by activities at the national level. So currently, we're hearing that the components to operationalize electronic case reporting beyond the pilot phase will be ready in September 2019. So CDPH is actively working towards this timeline. But please note that there are many contingencies and dependencies that may affect these timelines, some of which we may have no control over. So the phase 3 there, the phase 3 implementation is the target date and really will be dependent on provider readiness and the ability to receive the EHR module that providers will incorporate into their EHR system that would allow for ECR functionality. So with that, I believe that's it from me.
Oh, it is. Thank you, Melanie. I'll pitch this. This is DeeAnne again. And I want to encourage folks that if you have questions, don't hesitate to use the chat box to type them in. We will be looking to that. So far, I don't see any entered. And we only have a few more slides left. But anyway, these are some resources that are available out at this webpage. A couple really nice outreach bulletins that ECR has published. So there's great information out there as a resource, another resource for you guys to learn more about this. Great information there, Melanie. Measure 4. So going back to the 5 out of the measures that are within this objective is public health registry reporting. So it's a little bit of a generic title that sort of matches the entire objective title, but it is different. It is its own measure. CDPH specialized registries are grandfathered into 2019 Stage 3. This is by way of CMS final rulemaking and as noted in the Federal Register. If the participants were in active engagement 3, that's the production, by December 31st, 2018. So some of the examples of these registries are the Cancer Registry, Smokers Helpline, National Survey. So what we've had up through modified Stage 2 was the immunization, syndromic, and specialized. Specialized is no longer one of the 5, but some of those can count towards your public health registry, and then otherwise that is not handled by CDPH. So it's a little bit of a gray area, but there's a lot of you who are in active engagement and will be able to use this option, this measure, for one of their 2 to meet the minimum of 2, but you need to have already been in active engagement by the end of calendar year 2018. And then measure 5 of the 5 is clinical data registry reporting. One of Melanie and Steve's colleagues was not able to join us today, so he was able to provide some information from CDPH that for California, both local health departments and CDPH have equal public health authority. Submitters should check the matrix, the capability matrix, to see what options are available at the local level if you want to be selecting the clinical data registry as one of your 2 or greater than 2. in some cases, the submitters need to use the local option for a public health measure instead of the state. And there's an example about the immunization is in San Diego is through local health, not through care that Steve spoke about. CDPH can verify what they're able to accept, but they're not able to say whether this is your meaningful use. So years ago, folks were really accustomed to and used to writing to CDPH saying, we do not administer immunizations. Can you give us an exclusion for this meaningful use measure? Those questions do still come into CDPH, and only the submitter, synonymous to an attester, can verify this. CDPH cannot verify, and they will not give you an exclusion letter. So I don't expect to see a lot of folks selecting Measure 5. I personally don't know much about it, but it's one of your 5 choices, and we can help you find information and how to attest to it if you need to, especially if 2 out of the other 4 are not your pathway to a successful meaningful use attestation for 2019 Stage 3. And everything we're talking about today should be the same, applicable for the next couple years. The Medicaid Meaningful Use Program goes through program year 2021. It's Stage 3 for everyone, even if an eligible professional only did AIU anywhere between 2011 and 2017, even 2018, then they are still eligible to jump right into Stage 3. Everybody is Stage 3 for 2019. And if they have not completed 6 years in the program, there are still program years 2020 and 2021 as viable program years. The California State Level Registry is the pathway by which you attest to meaningful use. So I wanted to show you how it looks, a little bit of the screenshot of how the State Level Registry looks once you've logged in. You have your reporting periods, your EHR certification ID that shows that you are on 2015 edition certified EHR technology. That is required for 2019 attestations. Then you have your meaningful use objectives, and even though the public health clinical data reporting is one of the meaningful use objectives, it has its own drop-down menu in a sense, along with the clinical quality measures. And then they are listed there over to the right, because this immunization, syndromic, public health, clinical data, and electronic case reporting, those are the 5. And that order is slightly different than the way CMS specification sheet lists the 5 measures, but they are, the 5. We do have some email addresses here available for everybody that if they need additional resources, we can and have questions. There's folks out here. Today's presentation wanted to essentially give you an electronic webinar meeting of some of the folks that are working behind the scenes to support these registries and what the California Department of Public Health is doing to help provide these registries so that end users out there can use them, and use them hopefully not only for meaningful use, that they're not blindly attesting yes, that folks are seeing the benefits of what it has taken to get bi-directional immunization registry out there to, Steve mentioned for a moment, decreasing what sometimes has been multiple data entry, having it one instance of logging in your EHR and having that report electronically to the registry, and then the bi-directional functionality, which is required of Stage 3. Hopefully that is meaningful and helpful to practices. And then the pilot that Melanie's been working on with the electronic case reporting, hopefully that goes a long way and brings a lot of value to our using the EHRs for all these years to be able to proceed and start using the data that's being captured out there for analysis and improving outcomes. Crystal, let me check in with you to see if you see any chat questions.
I do. We have one asking where a good place to get a list of the California registries is.
Okay. That should be, I'm moving back in this slide deck, this CDPH HIE gateway. And that's where then there's different boxes that you can click on, which then launch specific information. So if I go to hie.cdph.gov, gateway.ca.gov, then I should be able to see this gateway. Scroll down and say I'm looking for information on the immunization reporting. If I click that blue box, then it launches information about the California Immunization Registry.
Thank you, DeeAnne.
Sure. And I'm going to go to a slide of Steve's, and I'm going to ask Steve a question. So for stage 3 onboarding, I work, hypothetical situation, but I work for an FQHC that has been reporting and registered with CARE 2 for the last 3 years. Do I need to do new onboarding for stage 3?
Yeah, although it's a pretty easy workflow. So this allows us to queue up providers as well, the survey. If you're an FQHC, you probably only have to do this once with your central facility, just to make sure that your EHR can send the right messages, et cetera. So it shouldn't be perceived as an onerous situation. If in an FQHC situation, you'd only do this once, you wouldn't do it for each location. So you'd only have your central facilities sort of signing up and going through the testing process.
Great, thank you.
Sure.
And Melanie, I also thought of a question during some of your presentation, perhaps some of mine. If you can tell folks what CalReady is, the acronym. Not everyone may not know that.
Of course, I'm sorry. So CalReady is the California Reportable Disease Information Exchange. We are the state web-based surveillance section for infectious diseases, and we currently receive electronic lab reports, and will soon be receiving electronic initial case reports, as well as give the local health departments an area to log into to view their current incidences that are waiting for them.
Thank you. I'll check in with Crystal to see if she sees any. We will be posting this. If for some reason you're not able to find it through our website, don't hesitate to send an email to either myself or info@CalHIPSO, and happy to share the slide deck with you as well. And Crystal, do you see any other questions?
I don't see any other questions.
All right, great. So a little bit of promoting. CalHIPSO is hosting a Health IT After Meaningful Use conference on May 13th. We're 10 years into funding from the HITECH Act and the stimulus, and it's time to see what happens next. So there's a lot of movement still happening, people finishing their upgrades to 2015 edition certs, a lot of other mandates in the move from fee-for-service to value-based care. There's the macro MIPS world, which, by the way, public health reporting and under the Promoting Interoperability is still a part of MIPS. So there's a correlation to the non-Medicaid people who no longer have meaningful use, but they have MIPS to attest to. That all still is in play. And so what happens after the meaningful use years? So though we do have up through program year 2021 to continue as meaningful users in the EHR incentive program under Medi-Cal, CalHIPSO is hosting a conference in May for stakeholders to get together and convene and discuss what happens next. Where do we go from here? So please reach out if you're interested in that, and there should be a registration. Registration is open, and it's available on our website as well. And with that, we should be able to give you back 15 minutes of your day, unless there's any new questions popping in. Last check on that.
No new questions.
Great. Well, thank you for attending today, everybody. Happy New Year. And here's to a lot of folks staying with meaningful use through 2019, and we hope to help you get there. And with that, we'll close the webinar. Thanks, everybody. Have a great day.
Thanks. Bye-bye.
Thanks.